Welcome to The Blend, a podcast brought to you by the Journal of the Dermatology Nurse Practitioners and Physician Assistants. In the first installment of this four-part episode, Dr. Sonal Choudhary, a dermatopathologist, dermatologist, and director of the Integrative Dermatology and Skincare Clinic at the University of Pittsburgh Medical Center, and Jazmyn Phillips, a dermatology physician assistant at the University of Pittsburgh Medical Center, provide an overview of hidradenitis suppurativa and the toll it can take on a patient's quality of life.
Hello, and thank you for joining us for our third episode of the Blend podcast. We are recording a new topic today for you all to listen to. I welcome once again our advanced practice providers, physician assistants, nurse practitioners, and physicians in dermatology, and any other specialty who would like to learn more about integrative dermatology. We hope that we bring you some unique insight through our conversations about integrative dermatology topics. And today we have chosen to talk about hidradenitis suppurativa. Just to give you a quick intro on who I am Sonal Choudhary. I am a dermatologist and dermatopathologist, and most recently trained in integrative dermatology. And I am joined today by Jazmyn Phillips, another star physician assistant, who I would let her introduce herself now, and then we will go into the topic.
Thank you, Dr. Choudhary. I'm so happy to be here today. Just a little bit about myself. I did my undergraduate studies at the Johns Hopkins University in Baltimore, Maryland, where I studied molecular and cellular biology. I then came back to Pittsburgh, where I am from, and I did a master's at the University of Pittsburgh in biomedical sciences, followed by my master's in physician assistant studies from Chatham University. And I have since then worked in dermatology with Dr. Choudhary, and it is a privilege to work with her. And my interest in dermatology has been forever, as long as I can think of. I've always been someone who suffered from acne, which, I know was talked about last time, and there's so much going on conventionally and integrative with that. And I'm really excited to talk about hidradenitis suppurativa today because it's really a place in dermatology that integrative medicine has started to make a difference for patients.
Thank you, Jazmyn. I really agree with you. That resonates in how we practice dermatology in our clinic. Hidradenitis has become such a common disease to be seen. Now, whether it has to do with the newer medications that are available, new options for the patients becoming more aware of the disease state itself, and the fact that, even the primary care providers who they see sometimes as the first point person for this have started to recognize that hidradenitis is not just a condition where somebody's getting a few boils. It has a lot more impact than that. I think it has its sort of root in why a lot of people are now being seen in our clinics as well. And, just to begin, I want to give a definition to what we define hidradenitis as. It is known as a chronic inflammatory condition of the skin characterized by persistent painful nodules and abscesses and sometimes draining tunnels. And the common areas affected by these lesions are the axilla, which is, underarms, the anogenital area, inguinal area, perianal, and gluteal area. So in the gluteal fold. A lot of these, draining sinuses and painful nodules, they affect a patient's daily activities and their participation in day-to-day work and life activities really affects their quality of life. And the chronic uncontrolled inflammation can lead to irreversible tissue destruction and scarring. So there is a permanent damage that it does leave behind. And we know now that there are certain inflammatory cytokines, and I know we'll talk about this in a minute a little more, like tumor necrosis factor alpha, TNF-alpha in short, interleukin 17, IL-17 in short. Some of these pathways have come to light where targets can be identified and used as treatment.
Yes, I agree. There's definitely a degree of variation in HS and not one size fits all, which is why it's important that we look at all of the different causes, treatments, and integrative practices that we can use.
I don't want to undermine that mental health impact that it has on our patients. When people come to our clinic, how when we're talking to them, you can see in their body language how much effect it has on their demeanor, in their conversational style, like how they kind of don't feel so great about themselves. Some people will actually voice it. And to the extent that there are studies and meta-analyses showing that one of the most concerning associations of HS is with suicide risk. And they found that there was this 2020 meta-analysis that showed there was a twofold greater risk compared to controls of HS and suicide risk, even when they had accounted for certain confounding factors like depression, schizophrenia, bipolar disorder, all that taken into account, it was still one of the biggest associations. And not only that, it is not just the risk, but in fact, the incidence of completed suicide is so much higher in this population. I want to say it's like double of what it is in other categories of patients who are studied under this. So it has a huge impact, not just like, and suicide risk is of course one of the ultimate parameters to look at, but our patients often will have accompanying depression, anxiety, substance-related disorders. The pain can be associated with opioid overuse sometimes, alcohol abuse. All of this has been reported and something we see as well.
Yeah, it's really devastating, but it's also a quality of life issue. And what's really sad about that is there is a lot of misdiagnosis of HS. There has been recent studies from 2017 to 2020 that have all showed that there is an average delay of 10 years, which is a really long time for these patients to be misdiagnosed. And it just, that delay in care also creates a barrier to getting these patients the care they deserve.
I mean, the permanent damage associated with it itself is enough to warrant early care. And how we were talking about, like I was mentioning about PCPs as being the first point of contact, they actually did a web-based survey on that. And they saw that about 90% of the physicians, they knew that a diagnosis of HS is a thing, like that it exists. The fact that it can be clinically made without need for any other laboratory testing or biopsies and all that. However, only 23% of them actually felt confident in performing such a diagnosis. So while they would maybe start some kind of a conversation, but they were not the ones to make the diagnosis. And I think at that point, the patient does end up getting triaged or lost, unfortunately, to some kind of follow-up. So, I mean, I know that there's so many associated factors and some causations that are being sort of studied, Jazmyn. I mean, do you want to talk about some of the causative factors so we can kind of get into that section?
Yeah, there is a lot of them. And, primary care providers may encounter these things. So, what are some of the causative factors for HS? So, we do know that their primary role of immune dysregulation in HS, which basically causes what we call autoinflammation, or the body continues to attack itself. That also has a complex interplay with genetics, smoking, and environmental factors. Some of the associations with HS, which were found in a 2024 meta analysis, there is a significant association between HS and the female sex, HS and type 2 diabetes, HS and smoking. There also is a genetic component. We have found that there's about 30 to 40% of people with HS that have a first degree relative with it. And some of the genes include ones called NCSTN, PSEN1, and PSENEN. So those are just a couple of the genes that we know of.
Well, I mean, that is progress, right? Now that we're finding some genetic connections and actual genes that we can comment on, and that gives a little more information to the patients. And obviously, we are not doing these genetic testings on each and every patient, but the research is heading in a good direction. And with that, they have also found an obesity gene, actually, which is associated with, in its phenotype, with HS, and this is called SOX9. It has been linked to HS and found in this study that they reported in JAMA Dermatology. And while there's certain variants of this gene in the loci which are located in the enhancer regulatory elements, which are detected in skin tissue, actually. Now, again, we don't test this in every patient, but knowing that there is an obesity gene associated with HS it makes a foundation for certain conversations with the right patient. And you mentioned smoking. Smoking association has been so strongly been associated with HS that I always have this conversation with the patients who are smokers. Sometimes patients will reveal themselves that, yeah, I mean, I do smoke, and I do ask them that. And sometimes when, truly speaking, if I'm walking into a room to talk to a patient first time or even as a follow-up, and I can smell like that somebody, is a smoker, they have smoked just recently, I can sense that. I do bring that up as a conversation. I said, are you still smoking? Are you a smoker? Cigarette smoker specifically. And if they say yes, we do have a conversation about how much impact that has on their HS. Again, JAMA published this nationwide cohort study with a very large number of Korean participants. I think it's like 6 million Korean participants in it. They showed that they quit smoking, and when they quit smoking, the quitting part, they were associated with a statistically significant lowered risk of HS onset compared to continuous smoking. And in fact, in the opposite sense, those who had quit smoking, but then they resumed, and those who had no previous history of smoking, but then started to smoke, they actually developed similar risks of HS onset as those who were sustained smokers. So smoking, just bottom line, is not a good idea if you have HS or you have that high risk of HS that runs in your family.
That's very interesting findings on smoking, and a big reason why we discuss smoking cessation with patients. Another thing that we talk about with HS is hormonal imbalances. So the development of HS is more common in women, as previously stated, and we believe that could be influenced by hormone secretion, particularly androgens, especially testosterone, has been linked to HS because it can actually promote apocrine gland growth and secretion. In addition, there is a factors between PCOS, or polycystic ovarian syndrome, and HS. And there is a study that actually did find that the prevalence of PCOS among patients with HS was 9% as compared to 2.9% in patients without HS. So, this analysis couldn't necessarily say, well, if you have PCOS, then you'll definitely get HS, or if you definitely have HS, you'll get PCOS, but there is an association between the two, which this is an important conversation for later when we talk about treatment.
Yeah, those are a lot of common things that you want to think about asking as questions to a patient with HS about, hey, do you also have PCOS? Do you also smoke, etc.? I want to kind of shift a tiny gear here and move towards something that doesn't always get discussed in a place like this. There are so many different staging methods. So HS requires some degree of staging. Why? Because, when you have a patient, you want to be able to stage their HS. So there is documentation on staging, something that insurance likes to see. There are different insurance requirements, as we know, that's something that we often have to prioritize when we are picking a medication for a patient, because ultimately it becomes a determining factor. So I just want to quickly highlight names of certain staging techniques and then couple that are actually very beneficial in documentation purposes. So Hurley staging system is been around for the longest, and often insurance companies will want us to have that mentioned. What is the staging of your patient's Hurley? Is it a stage 1, 2, or 3? Because those are the 3 stages. And one is like milder disease with single or multiple abscesses. Stage 2 becomes more recurrent abscesses with tract formation and scarring. Stage 3 is a much more near diffuse involvement with interconnected tracts, etc. And this is a simple, widely used technique, so that's a good thing about it. But the con of that is it's a pretty static measure. Like on that particular day, you get a snapshot of what their HS is doing, but it does not take into account disease progression or activity. Maybe 2 days ago, the HS was much worse, and we missed that because they were not in clinic. There are other better ones that are now out there and often used as research tools. So one of them is called HISCAR, HISCAR, Hidradenitis Suppurativa Clinical Assessment and Rating. Just to familiarize our listeners to this name of this score, I'm not going to go into the details of this, but just know that HISCAR, the pros of this score is that it's more comprehensive and it incorporates that active disease and scarring in its calculations. The con is, again, that it requires a much more detailed clinical exam and documentation, and it is not always possible to cover something like that in every single appointment. And then there are other ones like Sartorius scoring system, one called International Hidradenitis Suppurativa Severity Scoring System, IHS4, because there are 4 S's at the end of it. So these are like, the ones that exist. So just know that names of these staging things exist. Jazmyn, can you discuss a little bit about the pathophysiology of HS beyond, when you mentioned that there is an association of inflammation in this disease state?
Of course, of course. So, and a lot of this is, known fact about the pathophysiology from a 2023 systemic review. So we know that there's 2 main components to the pathophysiology of HS. We are unsure which happens first, but we know that it kind of turns into this feedback loop that just continues causing the HS to progress and get worse. So the first one is follicular occlusion. And basically what that means is there's a blockage of the follicular portion of basically the hair follicle unit. The second part is immune dysregulation. So we know that there's abnormal immune activation that kind of results in this persistent inflammation and skin barrier malfunction. The 2 immune players that we know really play a role in this, which Dr. Choudhary did mention previously, are tumor necrosis factor alpha and interleukin 17. And those are also 2 important things to keep in mind when we discuss therapies later on. And, the microbiome, which really is exciting place for us, is kind of where the integrative part of things really kicks off. And we know now that the microbiome has especially in the gut, plays a large role in HS as well.
Yeah, we will definitely touch upon that.
We hope you enjoyed part 1 of our 4-part episode on integrative approaches to treating HS. Thank you for listening to The Blend. We'll see you back next time.